Good afternoon, everyone, and welcome to the World Wellness Group webinar series for our 10th birthday. Today, we're going to be talking about social impact measurement in multicultural health. A very warm welcome to all of you. I'd like to begin by acknowledging the traditional owners of the land on which we are conducting the webinar. We are on Turrbal and Yagara lands. We'd like to pay our respects to elders past, present and future. And we commit to growing and nurturing our relationship with Indigenous Australians, to assuring their rightful place in the journey that is better health outcomes for Australia, and exploring the opportunity for partnership and collaboration to benefit all. Before I do official introductions of the presenters today, I just wanted to acknowledge that it is actually our 10th birthday today for World Wellness Group. So instead of stepping you through this slide that we generally step through every week, we'd like to share with you, we're going to actually launch our new video, which is the Our Story video. So enjoy that for just a couple of minutes. And then we're going, it actually really relates directly to social impact measurement. So enjoy the video and then we'll get started on the webinar.
Australia is one of the most multicultural countries in the world, yet our health system does not reflect or cater for this.
We are a clinic for the multicultural community run by the Multicultural Health workers.
We believe that everyone has the right to the 3 A's: affordable, accessible and appropriate healthcare, regardless of who they are.
As health workers, we saw a problem and we decided to do something about it.
We started World Wellness Group with no capital. In fact, us 5 co-founders, we all put in $500 each to get started, to get registered, to get insurance, and then we had to figure our way forward.
And that was the beginning of World Wellness Group.
But what really contributed to the success of World Wellness Group was our enormous social capital. Our networks and our supporters have really been what has made World Wellness Group the success that it is. And with our social capital, we've gone from strength to strength.
Providing healthcare to the most marginalised people in the community is extremely challenging. In the last 10 years, we have achieved a lot, but we still have so much more work to do.
Our impact is personal, societal, and structural.
I came to know World Wellness Group due to my mental health issues that I went through regarding my visa. I wasn't able to work, and everywhere I applied for work, I couldn't get one. And because my first application for protection visa was rejected, and everything I tried, it was unsuccessful until I came to World Wellness Group and something just started to work.
The 2016 Telstra Queensland Charity Award winner is World Wellness Group.
We could not have done this alone. We have built a community of supporters over 10 years. Together, we will continue to work for health, equity, and justice.
Health, equity, justice.
Okay, well, I hope everyone enjoyed that video. And as I mentioned, the video is actually really related to our mission, to our work, and also our social impact. So today, our presenters are myself. I'm Marina Chand. I'm one of the co-founders of World Wellness Group, and I'm also a director on our board of directors. And I have a particular interest in social impact measurement and particularly multicultural data. And I was very much involved in the development of our social impact measurement framework. And presenting with me today is Connor, and I'm going to ask Connor to introduce himself.
Thanks, Marina. Thanks very much for the invitation to present here today. My name is Connor McGarity. I'm the Managing Director and co-founder of Risk Insights. We're a small specialist consulting firm that specializes in the analysis of data to evaluate major programs and projects. Most of our work
Australia
is
is one of the
sector
most
space
multicultural
for
country in the world,
governments around
yet our
Australia,
health system
but
does
also
not
we do a
reflect
lot of
or
work with
cater for
socially
this.
responsible businesses.
Thank you, Connor. So let's step through and now have a look at what we intend to cover today in our webinar. So first of all, we're going to have a quick look at theory of change. Then Connor is going to take you through, can we just go back to the previous slide? Thank you. And then Connor is going to take you through social impact measurement in health and how we developed our framework here at World Wellness Group to give you an understanding of how we put it together and what we are measuring. And then I'm going to share with you some of our own learnings about doing this work and what we've learned about some of our impacts. And then at the end, we're going to wrap up with a discussion about the power of data. So I hope it's going to be really useful for all of you. All right, let's now get started and talk about the theory of change. So you would have noticed that we've disappeared from your screen. The reason being that we will have quite a few charts in our presentation today, and it just makes the font a little bigger for you to be able to read. So, theory of change. Well, it might be stating the obvious, but all organisations are trying to effect a change on society in some way. In our sector, we are aiming for a change in the well-being of a group of people. And often we also try to impact on the social and systemic determinants that drive structural inequality. All services are trying to impact on social good at some level. Perhaps it's at the individual level, such as in health services, perhaps in the local community, like a neighbourhood centre, or across a city, perhaps a particular population or a group. It could even be the natural environment. Whatever we do, when we plan our interventions, projects or services, we inevitably have chosen activities that we believe will have the desired impact that we are working towards. Whether an organisation has a stated theory of change or not, most likely the leaders and the staff will have their theories about why they do what they do and what the intended impact is. So a theory of change explains how activities are understood to produce a series of results that contribute to achieving the final intended impacts. And a theory of change isn't just for an organisation. It could be for any level of intervention. It could be for an event, a project, a program, a policy, a strategy, or an organisation. So that's just in a nutshell what a theory of change is. And it's really the starting place for when you're developing a social impact framework. So on our next slide is the World Wellness Group theory of change. So if you look at our theory of change in the top left-hand corner, often a theory of change will describe what it is that we're trying to solve. So in our case, that is health inequity. And we have presented that through that picture. What that picture shows is the diverse populations who are represented through the different shapes, which represent needs. They don't fit through the front door there of the health system, which is largely monocultural. So our long-term goal is also depicted, which is in the top right corner, again through a picture, where the health system matches the diversity and the need in the population using it. So that's our long-term goal that we are working towards. And in the middle, in the orange text, is our vision and mission. So in our theory of change, what makes ours, I guess, not necessarily unique, but I just wanted to draw your attention to it, is that we have two distinct levels of intervention above that pink line. So above the pink line, we're working at a systems level, trying to impact on the system. And below the pink line, we're impacting directly by providing health services. So our theory of change really reflects on this. And at WWG, we often say we provide services in the system, which is below the line, while working on the system that creates health and equity in the first place. And that's above the pink line. So together with these two levels of intervention, the theory of change identifies the impact we are working towards. I just wanted to just draw your attention to something, and that is that our theory of change, or any theory of change, isn't necessarily linear. It's not like a program logic where you've got a particular input that you're trying to use to get a particular outcome or impact. A theory of change is a little bit messier than that, even though ours looks quite neat, but it actually doesn't line up right across horizontally. So a theory of change is a series of inputs or activities that together will produce those outcomes or impacts that we are working towards. And a theory of change also will include the big picture, which in our case is health system inequity, which is there right at the top in terms of our long-term goal and our vision and our mission. Okay, so I hope that that's given you a bit of an introduction to theory of change, and I'm going to hand over to Connor now to talk us further into theory of change and the health system.
Thanks, Marina. So just picking up on what you were saying there about WWG working on the system while working in the system, let's see what the system actually looks like. So what you've got on your screen here is a pictorial that shows Australia's health landscape. And it is quite complex right off the bat. You can see that there are various tiers and levels of activity, and WWG operates up and down these tiers. So, for example, if we look at the bottom tier, that's the blue color, we have the social determinants of health that are central to the work that WWG does with its called clients. Moving up to the green tier then, if we look to the right-hand side of the diagram, there's specific health promotion and disease prevention work. And you can see on the very far right-hand side, mental health, which is obviously a key focus area for WWG. Then jumping up again to the red layer or orange layer just above it, and you can see the role of primary health networks and their important role in the community. And this is a group that WWG works closely with. So what's the purpose of this slide? Well, the purpose is to convey the complexity of the health system and to demonstrate that it's very easy for smaller healthcare entities to get drowned out, particularly when there are ongoing health challenges and wicked problems represented here in the blue box on the right-hand side. So with that constant threat for smaller players, how can we maintain our focus and our relevance? Well, one important way to do this is by having a way to measure our impact. And this is where a social impact framework is useful. So what is a social impact framework? In essence, it's a roadmap to help an organization deliver on its vision through the way it captures, analyzes, and reports on information and data. So let's look at the main building blocks we have here on the screen. So firstly, starting at the left-hand side, we need to understand the barriers we face to achieving our vision. These could be at the system level or at a service delivery level. Moving along, next we need to understand our current activity. What are the inputs we are providing to try and tackle these barriers? Or what are the inputs or activities we need to provide in order to overcome the barriers? Thirdly, we need to be able to identify the services we are delivering, measured in terms of outputs. So these are often things that are traditionally reported as measures of productivity or performance. Things you can count generally, such as number of clients accessing services or number of GP sessions delivered. Closely linked to these outputs then is outcomes. Outcomes are generally more difficult to measure than outputs, and they can often have a longer time frame to become evident. They usually relate to system performance more broadly, rather than more individual transactions, or results for a particular cohort. And lastly, what we're aiming for is our impact. What have we achieved overall as an organization as we work towards our vision? So this is the conceptual framework. Let's see a really simple example of that in action at WWG. So let's go back to our barriers. Let's take a real life barrier that causes health inequity. Language barriers faced by migrants and call communities, and the fact there's a significant issue faced by many WWG clients with this barrier. What's the solution? WWG has a focus on using interpreters in its GP clinics. It also has a team, like we saw on one of the previous slides, that speak many languages. What's been the effect of this approach to this problem? Well, WWG has experienced a greater uptake in services as a result of this focus on use of interpreters. And how does this translate then into outcomes? Well, there's improved access to health services as a result of this one practical measure, which has led to better overall health, client health and well-being. And in fact, we'll look at some data a little bit later in this presentation that shows that WWG clients come from near and far to use our health services. So we looked at the 5 main building blocks of WWG's approach to its social impact framework. But as Marina mentioned, we're trying to create impact on the health systems in place, as well as the services we deliver. So these are the 2 central pillars of WWG's work. But for the purposes of today's talk, let's focus on how we can influence and impact the system using our impact measurement approach. Let's quickly step through what that looks like in real terms. So again, we go back and we start with identifying the barriers that exist to us delivering on our vision. In this instance, we've just included 2 examples of barriers in the grey box: low cultural capability, data and knowledge in health systems, and the lack of culturally appropriate policy, programs and services. Significant impediments. The blue box at the top of the slide serves as a reminder of our vision for health systems, whereby there's equity for a multicultural population. So going back to one of the earlier slides, where the doors were shaped so that every person can enter the health system. So this vision should always be front of mind when we're identifying barriers to successful impact. So now we've identified the barriers, we look at what we can do or are doing to overcome them. And this takes us to the inputs and activities we're providing at WWG. So here we've just got a few examples, including advocacy based on call data collection and strategic engagement with others in the health networks that we talked about at that landscape level. You'll start to see a pattern emerging here of more and more reliance on data to help influence discussions at a system level, whether that be with the Department of Health or PHNs or other primary health providers. Moving through our social impact framework, we're starting to see some of the outputs and outcomes that support the vision. For example, WWG continues to collect and indeed refine its data collection, which informs research and education programs and policy design. And finally, when you put it all together, here's what the building blocks look like at a system level. So here you have the interlinked components joining up to improve the system from within WWG's sphere of influence. Now, this is just a simplified version of what happens in day-to-day implementation. but it's useful to show how the components interact. It's useful for explaining to stakeholders, it's useful for seeking funding, and it's useful for making sure that we are all headed in the same strategic direction. But we'll only ever achieve our vision if we're measuring our performance as we go, and this is where the data comes into its own. So what does that look like in practice? Well, sometimes you're collecting data you don't even know is being collected in your own organization. Sometimes you're collecting it and you know that you're collecting it, but you are not using it for anything. And other times you may have a vision to deliver a service, but have no evidence of the demand and what that looks like or how data can help you. But having a social impact framework provides you with a structured approach for collecting, analyzing, and reporting data without getting overwhelmed. In this example, the blue boxes show some specific data points we are collecting here at WWG to overcome particular service barriers. So, for example, on the far left blue box, we are collecting data on GP appointments, client postcodes, telehealth appointments, as indicators of the provision of more accessible health services, which you'll remember, that's what we're aiming for. In the middle box, we're analyzing data on those clients that use more than one of our services. And really, this is an indicator that we're achieving success in culturally inclusive models. So basically, success begets success. If we get it right for a client for one service type, maybe because we literally spoke their language, because we use interpreters, that client is much more likely to use our other services. The end goal of this data collection analysis is data-driven outcomes for clients. So that's where we have the bottom of the diagram, as well as data-driven impact for WWG. So a great example of this tangible success is the fact we now have data to demonstrate how our services are leading to an increase in our clients' mental well-being, shown here in the yellow box. But it's not all plain sailing, and a focus on data requires continual iteration and fine-tuning. Here are some things we have learned along the way. Back to you, Maria.
Thank you very much, Connor. Okay, so now I'm going to step you through what our process has been implementing a social impact framework in WWG. So let's just go to the next slide. So I just want to share with you, firstly, I guess some learnings and I guess how we did it, information. And please, if you have any questions, please pop them in the chat box. We do have some time at the end for your questions, but if anything isn't making sense, please make good use of the chat box. So I guess once we developed our social impact framework, part of that framework is actually a data plan. So you have to start with a data plan in terms of implementing your framework. Identifying the most appropriate data indicators is actually a huge piece of work. And for some indicators, we really struggled, to tell you the truth. The easy ones were things like ethnicity, country of birth, interpreter required, lifestyle factors, which is a common thing which we collect in primary healthcare. But much more challenging, but really important to our work, were things like cultural safety, financial stress, housing stability, access to technology and the internet. So it actually took a bit of time to work through and come up with a data plan that had appropriate indicators that we wanted to collect. And the next piece of work was to map that against our existing databases. So on that second point, collecting the right data is a process. It sure is. Just like most of you on the webinar today, I'm pretty sure that we all have a common experience, which is that we often, once we really dive deep into our data, we realize that we're not actually collecting the data that we really need. Like most other organizations, our data collection systems are really oriented to service delivery, and in our case, health service delivery. So we use medical software, just like other GP clinics, which won't allow us to collect really important indicators for our social impact framework, such as the social determinants of health or cultural diversity even. So we are progressively implementing a data plan by chewing off bite-sized chunks. Collecting the data that you need is an ongoing process, which I'm sure all of you would know if you're down the journey as we are. On that third point, balancing between data collection and service provision. We had to really identify the not negotiable indicators and work out how to embed these in our admin and service provision templates to ensure that our staff would be able to collect them routinely. I guess in any human service organisation, there's a bit of a tension between collecting appropriate data and your service providers not feeling like we've turned them into research assistants and finding the balance between that. So this is like a negotiated process. So we had to go through that negotiation process, and we are still on the journey of looking at our data quality, and we are striving to improve our data quality, and we routinely review our data and look at how we can improve on quality and coverage. So on the next dot point, embedding pre and post data collection is also really important, so that we're not turning, our staff into research assistants, as I said. So one of the examples which I'll give later is that we've been able to embed a particular instrument, which is like the K10, which those who work in health or mental health would have heard of. It collects the level of psychological distress a person is going through. So we now have that embedded so that it is routinely collected before a person starts with us. And we now have a follow-up process where we phone a selection of people who have finished their services with us, and we check in on them, and we check on things like their social isolation, social support, health literacy, cultural safety, their occupational, financial stress and well-being, and then we make sure that that K10 data has been collected as well. And just on that last point, we'll discuss that a little bit more later, but just wanted to mention that one of our learnings is that systems interventions are really difficult to measure. And this is mainly due to attribution being much more difficult when we're dealing at a systems level. All right, now let's move on. And I'd just like to share with you a little bit close up, I guess, some of our learnings. A really important measure to us, as what Connor has already gone through when he looked at barriers, is the issue of accessibility. So our social impact framework identifies that overcoming access as a barrier to healthcare for CALD populations, that should be measured. So we have started to measure our performance on overcoming different access barriers. It isn't just about language, there's a whole range of barriers. So in that top corner in the yellow are some of the inputs that we use to overcome these. So we do outreach and home visits to overcome geographic barriers. We ensure that our services remain free or low cost to overcome financial barriers. We also have various programs to ensure that visa status isn't a barrier. We ensure that culture and language support is provided. We are very mindful that we need to remain a culturally diverse organisation ourselves, and I'll talk a little bit more about that, and also the use of culture-based models. So those last three that I've just mentioned that have a little star beside them, those three inputs kind of straddle our entire social impact framework because these are actually really important to overcome accessibility, but also to provide culturally appropriate healthcare and health promotion. So they're really key. So the outcomes we are working toward is improved access to health services and programs. So going down some of our measures in terms of trying to achieve accessibility. So for people on lower incomes, 99% of our services are free. So only 1%, there is a small charge. So that is what we are contributing to provide accessible healthcare. The second dot point, so people seeking asylum are specifically locked out of the health system if they don't have access to Medicare. And approximately 30% of all people seeking asylum in Australia don't have access to Medicare, and many don't have work rights or adequate income support. So that's a massive accessibility barrier to healthcare. The way that we overcome this is by providing access to healthcare, and most of that is done pro bono. So there we have a measure which is a financial measure of the pro bono work that we do to ensure that people seeking asylum get access to healthcare. Another group of people who don't always have automatic access to healthcare or other supports are international students. And particularly during the pandemic, international students found themselves being locked out of many of the safety nets. And last year, the data on our Multicultural Connect line showed that actually 25%, so that's 1/4 of our callers, were international students seeking help to navigate access to a whole range of supports. So that's a really important finding that we wouldn't have known had we not looked at that data. The next one down. So for people who have a language barrier, we have a higher than industry interpreter usage rate in our medical clinic. So in Australia, just under 1% of GP appointments use an interpreter, a professional interpreter. In our GP clinic, that is 16%. And you might think that's quite low for a multicultural clinic, and it is, even though it's much higher than the industry rate. That's actually because a really significant number of our appointments are done in language. There's a language match because we have multilingual GPs. So what we're working on now is a measure so that we can capture that, because once again, the medical software that we use doesn't allow us to capture that routinely. So it's an ongoing process of putting the puzzle together to create an accurate picture. So hopefully this time next year, we'll be able to tell how many appointments are done in language. Overall access, we actually really keep oversight over this. For the last financial year, the overall proportion of CALD clients versus non-CALD clients was 75-25. Again, you might think, well, that's pretty obvious for a multicultural service. But don't forget, we are a social enterprise and we are available to anyone in the community who would like to use our services in the clinic. So what happened during the pandemic when the COVID vaccine was first available to people is that just like a lot of other clinics, we had an online booking system for that. And what we found was that people from a non-CALD background were really savvy at getting online and booking themselves in straight away. And all of our appointments got snapped up literally overnight. And we were booked out for weeks in advance. And what we found was that our CALD clients were actually locked out, which wasn't our intention at all. So we had to switch off the online system and use different admin processes that take a lot longer, but to ensure that CALD clients had access. So we always maintain this oversight of the CALD status of all of our clients, which is around 25-75 split. So that's a bit of a snapshot of some of the measures around accessibility. Let's now have a look at the next slide, which is the cultural safety and well-being. So again, if we look at the inputs, what's important to cultural safety and well-being is peer support and lived experience, wraparound care, having a culturally diverse staff, culture-based models, and again, cultural and language support. So if we look at some of those measures, so we provided cultural supports to our clients via our multicultural peer support workers. This is in the non-GP clinic. for 1,197 sessions last financial year. So that was 15% of appointments had an MPSW on board to provide that direct cultural support to our clients. What we do now, as I mentioned earlier, is we follow up people after we have finished working with them, and we actually specifically ask questions around cultural safety. So we ask them about the quality of the cultural support they have received, and we ask them about their experiences of being culturally respected, heard and understood, and also if they ever felt experiences of discrimination or racism, which is a really important part of cultural safety. So hopefully this time next year we will be able to report on that really important outcome area. Now, we're really conscious that the health system doesn't reflect the people that it serves, and it's important that we keep oversight of that in our own organisation. So as you can see up there, 95% of our staff are from a CALD background, and that's across all levels of the organisation, including our board. And we collectively speak 55 languages, and that little word cloud on the side gives you a bit of an idea of some of those ethnicities that we took from the last staff survey that we had. And I guess a lot of organisations have got diversity targets, and it isn't just about cultural diversity. Cultural diversity is very important to us, but we also measure other types of diversity. Okay, and then the pre and post data that I mentioned earlier, which is important to cultural safety and wellbeing, is the K10. So when we looked at that last financial year, what we found is that there's a 10-point difference between the pre-scores and the post scores. So the K10, for those who are not familiar, is a 50-point score. And so when you get a 10-point difference, you actually go into a different level of psychological distress. So we've been able to demonstrate quite a significant drop in psychological distress through our service provision. So this is an example of a measure that we now have that helps us to piece together, I suppose, the level of cultural safety and well-being that our work contributes towards. So let's now go to the next slide and have a look. Oh, thank you, Paul. Thank you for the comment. Now, let's talk about systems impact. So systemic impact is actually much, much harder to measure, and that's because of attribution. It's actually really tricky to claim that whatever we did at a systemics level impacted, completely on the system. So what we are doing now is really turning our attention on how to measure our systems work. So we are currently working through an online data collection tool to capture our systemic work under those 4 domains. So especially some of our senior staff who do a lot of this work are now on a monthly basis collecting information about their advocacy and advice work, their involvement with research and data, multicultural data, training and education, and also the development of multicultural health models. Now, one thing I did want to say is one major systemic outcome we did achieve that we can claim the credit for, I suppose, or claim the impact for, was that in the last financial year, we established the MCL, the Multicultural Connect line. So this produced systemic impact for multicultural health investment, for the development of models of care, and even data. The MCL collects really powerful data on the needs of its callers. For those of you who tuned in last week, some of that data was shared, and we'll have a really brief look at some of that a little bit later. I guess for us, what we realised that by collecting adequate data on the helpline, that we could see that the trends in our data was directly reflecting what was going on in the community during the pandemic. For example, during the Afghanistan crisis that started a few months ago. At that time, the vast majority of our callers were from an Afghan background, calling with high levels of distress and need for navigation support. And so what we're finding is that that is actually a really powerful tool for us to understand what is going on in the community and how to target our efforts for support. Which is a great little segue to our next slide, which is the power of data. So I'm going to hand back to Connor to talk us through.
Sure. So look, there are many, many things, quite obviously, that we're doing better now, that we've got more of a focus on data. So, but there are just four sort of key or principal things on this slide here. So the first one is profiling our clients. We probably know our clients better now than we ever have, even though the pandemic highlighted a lack of reliable multicultural health data more broadly across the country, and certainly a limited ability to share any of that data. So we are continuing to build our own data holdings in that respect, but we certainly have much better insight into our clients. Number two, what do clients need in terms of services? So during the pandemic, as Marina just said, and especially through the collection on the Multicultural Connect line, we had a focus on collecting data that would highlight demand for specific services, as well as inform the planning and design of any new or improved services. And we'll see what that looks like in a little second. Thirdly, data is obviously a strong evidence base. It helps with advocacy and can help create a compelling narrative for engagement with external stakeholders about what multicultural health services look like, but also where there may be demand that is falling through the cracks. And that takes us to number four. Finally, data helps us isolate those pockets of demand or geographies where there may be previously unknown demand. So in this way, it helps surface vulnerable populations that may otherwise not be forthcoming to seek help. But I would just finish on a note of caution here. And while obviously data is very powerful and helpful, don't be too ambitious with your data work right at the outset. Start with a stock take of what data you already collect before you head off on new collection methods, because it can be time consuming and costly if you try to do too much too soon. So here's what some of those analyses look like based on our new data. And some of you may have seen these diagrams and charts previously. So what we've got here is a very simple representation of data collected through the Multicultural Connect line during COVID. It allows us to profile our client base. In this example, we can see cultural backgrounds, language, visa status, and country of birth. So that's always helpful. Just moving on to the next one. Identifying client needs. Again, just a snapshot in time here, but WWG is working towards identifying which discrete issues its clients are calling about. So this can include multiple issues in a single call. But again, the beauty of this is it allows you to gauge any emerging issues that may need particular attention, or there is a need for referral to another health or social welfare provider. And if you just look down the topics on the left, some of the issues being raised, you can see the diversity in those issues ranging from financial hardship to mental health, domestic violence, and food insecurity. The fact that people are raising these with WWG suggests they have a sense of trust in the services being provided. So they're happy to raise the issues with WWG, even though ultimately they may need to be referred elsewhere. And lastly, another simple graphical representation of the geographic spread of WWG services. This one's maybe a little bit hard to read, but all we've done here is plot some of the patients' home postcodes, where they're coming from to see us. If you look closely, you can see the WWG symbols near the center. So each blue dot represents a client's home address. So why is this data useful? So obviously it can assist with service design and location, but more than that, we want to keep people out of hospitals generally at a system level, going back to that higher order matter, because we know they're already struggling for capacity in the hospitals. And in this example, you can clearly see that WWG clients are traveling from far and wide to access our GP clinic and mental health programs. In fact, about 21% of our patients Across several of our health programs, travel more than 20 kilometers to see WWG. So again, this is a really simple example, but the use of this type of data can provide compelling support for discussion with other influential stakeholders. So data really is the fuel to help us deliver on our social impact framework. And that concludes for the data bit, Marina, so I'll hand back to you.
Yeah, thank you. And we might go to the smaller screen. Thank you, Amin. So it kind of concludes, I guess, the formal part of our presentation. What we wanted to do today was share with you, I guess, some of the theory how to do this work. That you start with your theory of change to identify your big picture mission work, and then identify what your theory is of how to achieve those impacts, and then your data plan. And we hope that by sharing how we are on that journey, and it is by no means complete, I guess how far we have been able to come along this journey. And I hope that it has been useful. And I'm just kind of throwing it open now to see if anyone has any questions, because we're really happy to answer your questions. So please, use the chat box. And while you're having a think about your question, I might just put in a plug for the last webinar in our series, which is next week, same time at 1 p.m. So this is a webinar on a really important topic that's very close to our hearts. It's on multicultural lived experience and developing a framework from the bottom up, which is what we did here. And that's going to be presented by Rita, Prasad Ildish, and Sharon Weir, who worked on this framework for us. So that'll be at 1 p.m. Next week. Thank you, Alice. Thank you. I'm glad it was useful. Are there any questions? We might just leave it open for a few minutes. Or perhaps there aren't any questions. We might just put up our, here we go. I'm wondering if there is any preliminary data on cultural safety. We don't have that as yet. We would love to actually do one of these webinars again when we have that pre and post data. And Alice, I have to say that for us to actually figure out some of the indicators for cultural safety was almost like a research project in itself. And we ended up actually looking at some work done overseas on how you measure that. And we've taken some aspects of that and embedded that into our interviews and our data collections. We don't, because we really started to implement that pre and post process this financial year. And because we're only 5 months in, we just don't have enough data to be able to share with you just yet. But really would love to do that again down the journey. And happy to share, because I think transparency is important. And happy just to share even, I guess, the questions we're asking. If that's helpful for you, I could certainly, email that to you. But yeah, cultural safety is a really big issue, and we know that, and that's why it's definitely front and center in our social impact framework. I might actually go to our last slide, which has our contact details. Oh, hang on. You mentioned about the impact of the role of MPSWs. How could this impact if we do not use? How could be this impact if we do not use this resource? So in terms of cultural safety, Arta, I guess we use the multicultural peer support workers to provide their lived experience in a peer-to-peer environment, and cultural support, language support, migration, lived experience, a whole range of supports are provided by the MPSWs. And definitely our impact would be much less if we didn't have this resource, that's for sure. I think we actually rely on the multicultural peer support workers a lot especially for cultural safety. So yeah, if we didn't have this resource, the impact would be far less. That's for sure. So we might just an acknowledgement more than a question. Data that was shared with me from MCL was used to advocate with MAC during the height of the pandemic. Yes, thank you. Thank you, Paul. Yes, that's right. And actually, the data that we shared just before on the MCL, that's flipped again when we looked at it just recently, that I think mental health is now front and center at the top. And that's what I mean about that. It's almost like a litmus test of what's going on out there. So earlier in the pandemic, when people were losing their jobs and financial aid was really, really central, we were seeing that coming through really strongly. And now, just like other services, you know, the mental health impact of the pandemic and just what's happening out there in the community is very front and center for us. Demand for mental health services has gone up, I think they said 200% in our organisation. I think they said that last week at the webinar. So yeah, data is powerful, so for sure. So in terms of Arta, your other question, the difference to using interpreters. So there is actually quite a big difference between a multicultural peer support worker and an interpreter. So if we use the classic role of an interpreter, they are there as a communication aid. So they are there to interpret what is being said between, you know, the client and the practitioner in our organisation, for example. A multicultural peer support worker brings much more than language ability. Multicultural lived experience is so multifaceted, and in fact, tune in next week. That's a great actually advertisement for the webinar next week in terms of what that actually means. But providing cultural support and providing, I guess, contextual information both to the client and to the health practitioner is really important to ensure that there is great engagement and understanding and a partnership towards health and healing. So it's actually a really big difference between interpreters and multicultural peer support workers. But yes, please tune in next week to really drill that down, because that's exactly what they're going to be talking about next week. So if there's no other questions, we might go to our last, oh, there was another question. Sorry, apparently there is another question. Okay, if there was more multicultural health data available, what impact would it have on the health system? Oh, that's a question close to my heart. So, I mean, anyone that works in multicultural health or just in the multicultural sector or just in the health sector with an interest in this would know that that's probably one of our biggest issues that really plagues us in many ways. And the fact that we don't have enough multicultural data means that we can't do our advocacy work adequately. We cannot, I guess, put forward bids or advice around appropriate health investment. It doesn't allow us to have an environment in which we have, I guess, inclusive health policy and planning. Like the impact is just massive. And that is really, I suppose, an issue that we are really looking at closely in our organisation. And it is something that we really want to do something about. I think the first 10 years of our organisation was very focused on health service delivery. And now we want to kind of look up at the system and really try to impact that particularly. And I guess by us collecting adequate data in our organisation, we are contributing towards having some data, but it isn't enough. We need to have it embedded across the whole health system for sure. Arta. So by your description, did I get it right that MPSWs are part of the healing process? I would say yes, Arta, because why is, as I mentioned, MPSWs are so much part of people feeling safe and for to facilitate engagement in the health and healing process. And I guess here we use MPSWs integral to our mental health services, where healing, it is a long-term process. So I would say yes, for sure. Yeah. Okay, I think we might almost be no bother at all. Thank you for asking questions, Arta. That's great engagement. Thank you so much. Really appreciated your questions. So thank you so much for joining us. There's some contact details on your screen now. So if you have any other questions, please send us an email. We are going to be uploading these webinars on our website on the Knowledge Hub tab. So please check that out after we complete the actual series. We'll edit these videos and then we will upload them. So thank you so very much, and have a great rest of the day. Thank you.